One is the distensibility of the vein. All of us know that the veins are very thin-walled and very compressible, and in addition to that, they can accommodate large volume of blood without increase of pressure. Let's have 6 hemodynamic parameters. Most important is the flow, and these parameters are the same as the arterial side, but with some differences in both. Will not bother you much, but very important, the flow is very important, and soon we'll have a look at some hemodynamic parameters. The 6 pumps, all these pumps cannot work efficiently without the presence of valves. The big pumps is the heart, diaphragm, foot, superficial venous pumps, and the calf pumps, and thigh pumps lastly, and we'll have some words about each of these things. Hemodynamically, we know that the flow is actually the pressure over the resistance, or the pressure gradient of the resistance. The more the resistance, the less the flow, as we all know. We have to remember that the velocity is inversely proportional to the total cross area, and velocity increases when the decrease of diameter. There is some resistance, some stenosis. The velocity increases at the stenotic segment. Let's have the viscosity also is a parameter important, and the resistance is related to the many factors, most important of which is the length of a tube. The longer the tube, the more the resistance. And we are all interested in laminar flow, the nice normal flow, and turbulence flow. If we have a look at turbulence, we'll notice that turbulence is actually complicated, but the factors are interrelated. Most of them, the diameter of the tube, the density, the viscosity, and the velocity, all are interrelated, and they are very much complicated equations. We are not much interested now, but very important that these are the four factors which increase or changes in these 4 factors lead to turbulence of flow. The point is about the veins. There are so many controversies. Any role of the sympathetic system, any role of venodilators, actual roles of foot pump, thigh pump, or role of the fascia. We'll deal with this in short tracks now. Very important to stress that there's a pressure gradient. We have a high pressure at the foot and much low pressure as we go proximally up the thigh till the heart, till we find the pressure 0 at the right atrium. This pressure gradient is very important hemodynamic thing. It's 90 millimeter mercury at the ankle, and as we go up, it decreases gradually. Important point also that the pressure decreases with exercise. That's why we ask our patients also to move, and this has a hemodynamic principle, actually, and the proved hemodynamic principle that there is ambulatory decrease of the pressure on exercise. One of the most important pump, there is agreement, this is the most important, the calf muscle pump. We'll not speak much about anatomy, but we know that gastrocnemius and soleus are the most important muscles. Very important that they contract and lead to less pressure in the area. There are so many proofs of this. We'll speak soon about the proof of this. They have an ejection fraction, and we'll see soon that these pumps had 20% ejection. 20% of the blood going inside the calf pump is ejected to approximately towards the heart. And this is proof that in case of CVI, there is increased pressure and less flow in the calf muscle pump. All these are proved now by plethysmography. As you know, I am a very old generation. we have very big plethysmography machine, but now we have computerized machine, but the same, now we have a real hemodynamic proof that this is a very important pump. Another thigh pump is some controversies about the importance. I don't know if you have this. There is the popliteal vein down, as you see. This popliteal vein has high pressure. The femoral vein inside the Hunter's canal cannot distend much. There is a very good safety valve. Some of the blood flows from the popliteal vein and next to the thigh muscles and then back to the femoral vein. This station in between decreases the pressure delivered to the femoral vein, which cannot distend much. It is imprisoned in the Hunter's canal. Thigh muscles, its importance arrived more than 20 years ago. These are more recent interests than the calf muscles. The controversies about the relative importance of this. Is it important or not? It is important, but sometimes so many people have osteoarthritis of the knee, some weakness of this group of muscles, and may not contribute much, but hemodynamically it's proved that they contribute to lessen the pressure in the femoral vein. So it is a very good hemodynamic principle to deliver blood indirectly to the femoral vein, which cannot distend inside the Hunter's canal. Let's speak about the foot pump. Foot pump. It's important because this is the first step of the venous return, in fact, because when we move, blood is sucked from the foot up to the calf pump. The point is that there are some anteriorly near the toes, there are some veins in the middle of the sole, and most of the blood is collected to the calcaneal veins, and these calcaneal veins are connected to the posterior facial vein and up to the calf muscle. What's nice in this, they found that there is some harmony between the foot pump and the calf pump. They call it even the systole of the foot pump is accompanied with the diastole of the calf pump. There is some receptive relaxation, contractions of the foot pump is accompanied by relaxation of the calf pump. From the hemodynamic point of view, the academic people do not consider this as an important pump because it ejects very little blood. Around, with each step, only 20 to 30 ml of blood is rejected. But it helps also to make dynamic things, to help all to relax the calf pump, which can accept the food. The point is that if you have osteoarthritis of the ankle, this pump is very weak. Second, little blood is diverted to the great saphenous vein. But the clinical evidence is strong. We have foot pumps. They found that, as you all know, very many devices which can make contraction, can make contraction and relaxation of the foot and help propel, help the venous return. So the evidence is clinical more than actually hemodynamic evidence. Some of the last pump, some people call it pump or not. To start with, I want to stress that everything I'm telling you is very controversial. Even some people deny the presence of this facial pump. But all of us now are doing duplex ultrasound. They will find that nice 2 layers of fascia, very strong posterior deep fascia, and thinner saphenous fascia, and the vein, great saphenous vein is in between. They found that with walking, there's some movement of the superficial over the deep fascia. There is some propelling of blood through the great saphenous vein, but the controversy is important or not. It is proved, but it is not proved as an important hemodynamic pump. It's still open to the discussion. When we speak about hemodynamics of the lower limb, very important, never forget the valves. It's easy to remember that valves direct blood in certain directions, but what is very strange for us all are the valves in the minute veins, 2 millimeter veins, and 1 millimeter vein even. We are just going through why so very small veins have valves. Do they contribute to the hemodynamics or not? This is the last message, is a pressure gradient when we stand and with decrease of exercise. Foot pump and superficial facial pump, still controversial. We need hemodynamic classification and need for computer-based hemodynamic studies. While there are valves in the very small veins. Thank you very much.
Thank you, Professor Azzeddin. I appreciate you are trying hardly to make things easy, but I know the venous flow is quite complicated. Dr. Azzeddin, do you mind to have one question from me? 3 questions after each speaker. Do you mind, or make it at the... Okay. Sorry for that. I have to obey the rule. Thank you.
Thank you.
Next speaker, Dr. Muhammad Tah, imaging modalities for perioperative endovenous planning and diagnosis of complications.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for all colleagues. Imaging modality for preoperative endovenous planning and diagnosis of complications. Imaging modalities for CT scan, ultrasound, digital angiography, and MRI. CT scan. CTA has been considered the preferred modality for choice for preoperative imaging and evaluation prior to aortic aneurysm like EVAR. CT is the best diagnostic pre-intervention planning study, accurately delineating the location, size, extent of the aneurysm, in measurement, proximal and distal landing zones, involvement of branch vessels, infrarenal angle and X vessel assessment, also for evaluation of all other organ, abdominal organ like liver, spleen, kidneys, para-aortic area, ascites, like this. This is, sorry. CPT protocol after EVAR. It's recommended post-EVAR CT imaging at interval of 3 days, 6 months, and 1 year post-procedures. CPT protocol is triphasic study. Triphasic for us radiologists means without contrast, early arterial, sometimes portovenous, and delayed scan. Include an contrast CT scan to differentiate calcification from contrast leakage and early arterial phase. Calcifications has attenuation value about 100, 120, and the fresh blood about 70, 90. After bolus, early arterial phase after bolus tracking threshold to detect most of endoleak, usually delayed 5 minutes to detect low flow endoleak, usually type 2 endoleak. To exclude other complications like device migration or kinking, graft thrombosis or occlusion, ischemia, or limb, bowel, or spinal cord. في معلش some problem, please. These are some complications of after EVAR, endoleak, types of endoleak, type 1, type 2, or type 3. This is here the most of complications by CT. When the aorta is dense like this is arterial early phase. When you become not ossified, phase is delayed phase. This can is like endoleak 3 from engraft, and this one infection ودي بيبص ان الاير black areas around the graft. This may be in نتيجة as a result of fistula aorto duodenal fistula. And this برضك at access site may be pseudoaneurysm at access site. The contraindications like in X-rays, reaction to contrast, renal impairment, will pregnancy. The ultrasound duplex ultrasound techniques used to increase blood flow in particular vessels, percutaneous transluminal balloon angiography, vascular stent placement, intravascular thrombolysis, intra-arterial infusion of vasodilator therapy. Ultrasound guided endovascular venous therapy, including endovascular laser ablation, EV-LV, radio frequency ablation, RFA, steam venous sclerosis, and endovenous microwave ablation. It is accurately locate and access the conditions of the affected veins, real-time imaging of the veins, allowing the intervention specialist to clearly see the location, site, and the shape of the affected veins. The specialist guide needle or laser fiber to the target vein, reducing the risk of the complications and ensuring that the treatment is delivered to the correct location. Also allow for real-time monitoring of the treatment, can adjust the doses or technique to ensure that the vein is fully sealed out. The advantage widely available, easy to use, less expensive, and non-analyzing radiation in X-ray, minimally invasive procedures guided by real-time ultrasonography imaging, reduce the risk, reduce the pain, faster recovery, no scarring, no hospital stay, lower cost. These are some pictures of transvaginal for varicose veins, pelvic varicose veins in females, and this is the MRI of the patient like this. The MRI, 3D contrast enhanced MRI imaging is highly accurate, depicting the location, extent, and diameter of an aneurysm and its relation to aortic branch vessels. MRI take more detailed image of blood vessels than the organs or tissue surrounding them as in conventional MRI. It is important to make a measurement of the aortic aneurysm from source image on which the wall of the vessels is visible, but M being maximum directional projection, images represent a cast of the human alone that will lead to underestimation of the aneurysm size. The MRI has a significant advantage compared to CT. It doesn't require large volume of contrast, but CT is faster. Unlike CTA, MRI is not able to see calcium deposits within the blood vessels, and the evaluation of small vessels may be difficult. Contraindication of MRI in general, cardiac pacemaker, surgical collapse, cochlear implants, renal implants, and early pregnancy. This is a picture of aortic aneurysm by MRI. Digital subtraction angiography. All طبعا vascular surgeon knows this technique. It is a diagnostic procedure to view the lumen of the blood vessels, arteries, and the vein. Injection of contrast through a catheter, usually in the groin, a femoral artery in the groin, with X-ray to evaluate the blood vessels. Radio-oblique structures, such as bones, are subtracted digitally from the image, then allowing for an accurate visualization of the blood vessels. Intra-arterial digital subtraction used for interventional vascular procedures like embolus therapy, transluminal angioplasty, or stenting, also embolization in pelvic varicose. A disadvantage, invasive, exposure to ionizing radiation, contrast allergic reaction, contraindication with impaired renal function, and pregnant women. The complications برضك contrast-induced reactions, angiocyte hematoma, or infection. These pictures of X-ray digital abstraction, plain X-ray at first, X-ray with the same on contrast, and subtract the bone to see the arteries. This is cerebral arteries, anterior cerebral and the middle cerebral will internal. This is a case of complication of the vascular procedures. Female patient came to the hospital suffering from chest pain, cough for more than 1 month. The X-ray chest has revealed linear, radio-opaque foreign body in the chest. CT scan of the chest without contrast revealed slip guide wire in the right and the left pulmonary arteries. From history, from the patient, failed insertion of portocat 3 years ago, and he's not alone. What happened? This is plain X-ray chest BA view. This is a linear foreign body seen in the center of your chest. CT scan. This was the pulmonary window. We see the الريدج اوبيك او الدنس الوايت جاير. This is the mediastinal window. We see also the guide wire in the right pulmonary and left pulmonary artery. This is in CT's construction 3D. You see the guide wire. See the guide wire. Thank you very much.
Thank you, Dr. Muhammad. Next speaker.
Next speaker, Dr. Khalid Atiyah, lower limbs varicose vein ablation guidelines.
Bismillah ar-Rahman ar-Rahim. First of all, I would to welcome my chairman and my professors for attending this meeting. Bismillah ar-Rahman ar-Rahim. Guidelines of lower limb venous ablation. These guidelines of the 2023 Society of Vascular Surgery, American Venous Forum, and the American Vein and Lymphatic Society Clinical Practice Guideline for Management of Varicose Vein of the Lower Extremities. Number one, evaluation of the patient with varicose vein. We recommend means guidelines recommend the use of 2020 update clinical stage, etiology, anatomy, pathology, SEEP classification system for chronic venous disorder. The clinical or basic SEEP classification can used for clinical practice, and full SEEP classification system should be used for clinical research. We recommend the use of the revised venous clinical severity score for patients with chronic venous disorder for grading of the clinical severity and for assessment of post-treatment outcome. For patients with chronic venous disease of the lower extremities, we recommend the duplex ultrasound as a diagnostic test of choice to evaluate the venous reflux. This is a strong recommendation. Compression therapy for patients with symptomatic varicose vein and the axial reflux in the great saphenous vein or small saphenous vein who are candidate for intervention, we recommend superficial venous intervention over long-term compression stocking. This is strong recommendation. In patients undergoing thermal ablation for saphenous incompetence with or without concomitant phlebectomy, we suggest post-procedure compression therapy for a minimum of 1 week for pain reduction. This is a weak recommendation. Pharmacological treatment in symptomatic patients with varicose vein who are not candidate for intervention or who are waiting for intervention or have symptoms after intervention, we suggest micronized purified flavonoid fraction or rhesus extracts for treatment of vein-related pain, leg heaviness, and sensation of swelling. This is a weak recommendation. Endovenous ablation versus high ligation and stripping. For patients with symptomatic varicose vein and the axial reflux in the great saphenous vein who are candidate for intervention, we recommend the treatment with endovenous ablation over high ligation and stripping of the great saphenous vein. This is a strong recommendation. For patients with symptomatic varicose vein and the axial reflux in a small saphenous vein who are candidate for intervention, we recommend the treatment with endovenous ablation over ligation and stripping of the small saphenous vein. This is a strong recommendation. For patients with symptomatic axial reflux of the great saphenous vein, we recommend either thermal or non-thermal ablation from the groin to below the knee, depending on the available expertise of the treating physician and the preference of the patient. This is a strong recommendation. For patients with symptomatic varicose vein and the axial reflux in the great saphenous vein or small saphenous vein, we recommend the treatment with high ligation and stripping of the saphenous vein if technology or expertise in endovenous ablation is not available, or if the venous anatomy preclude endovenous treatment. This is a strong recommendation. For patients with symptomatic axial reflux, great saphenous, we recommend either thermal, non-thermal ablation from the groin to below knee, depending on the treating physician and the preference of the patient. Strong recommendation. For patients with symptomatic axial reflux of small saphenous vein, we recommend either thermal, non-thermal ablation from the knee to the upper or mid-calf, depending on the treating physician and the preference of the patient. This is a strong recommendation. Posterior accessory great saphenous vein who are candidate for intervention, we suggest treatment with endovenous ablation with additional phlebotomy if needed, over ligation and stripping of the accessory vein. This is a weak recommendation. For patients with symptomatic varicose vein and axial reflux in great saphenous vein, who place a high priority on the long-term outcome of treatment for quality of life, we suggest treatment with endovenous laser ablation, radiofrequency ablation, or high ligation and stripping over ultrasound-guided foam sclerotherapy because of long-term improvement of quality of life and reduced recurrence. This is a weak recommendation. For patients with symptomatic axial reflux of the anterior accessory great saphenous vein or posterior accessory great saphenous vein, we suggest either thermal or non-thermal ablation with additional phlebotomy if needed, depending on the available expertise of the treating physician and the preference of the patient. This is a weak recommendation. Factor affecting choice of superficial truncal ablation. In symptomatic patient with CEP class 2 disease, we suggest against using truncal vein diameter to determine which patient need venous ablation. This is a weak recommendation. Intervention to preserve the great saphenous vein. For patients with early stage of symptomatic varicose vein, we suggest preserving the great saphenous vein using ambulatory selective varicose ablation under local anesthesia technique or compression hemodynamic correction of venous insufficiency technique called CHIVA, if performed by a physician who is familiar with this strategy. A weak recommendation. Treatment of venous tributaries. Symptomatic telangiectasis and reticular vein, we recommend sclerotherapy with liquid or foam. This is a strong recommendation. Treatment of varicose vein tributaries concomitant or staged with superficial truncal ablation. For treatment of patients with symptomatic varicose vein tributaries, we recommend ablation of the refluxing venous trunk and concomitant mini phlebotomies or ultrasound-guided sclerotherapy by compound foam or microfoam. This is a strong recommendation. For patients with symptomatic reflux in anterior accessory great saphenous vein or posterior accessory great saphenous vein, we suggest simultaneous ablation of the refluxing venous trunk and phlebotomy or ultrasound-guided foam sclerotherapy of the varicosities with microfoam or foam. This is a weak recommendation. Management of recurrent varicosities. For patients with symptomatic recurrent varicosities due to persistent or recurrent reflux of the great saphenous vein or anterior accessory great saphenous vein, treatment either with open surgical or endovenous technique may be performed with a good outcome of expects. For patients with symptomatic recurrent varicosis due to persistent or recurrent reflux at the groin, either endovenous ligation or radiofrequency can be used if there is a straight great saphenous vein stump. It is long enough for thermal ablation. Sclerotherapy or phlebotomies should be performed for recurrence due to new vascularization. For patients with symptomatic recurrent varicosities due to persistent or recurrent reflux of the small saphenous vein, ultrasound-guided foam sclerotherapy should be performed. Ablation of incompetent perforating vein. For patients with residual or recurrent varicosis due to incompetent perforator vein, treatment with both open and endovascular technique may be used depending on the physician experience, patient choice, and availability of technology. For patients with varicose vein CEP class 2 who have significant symptomatic axial reflux of great saphenous vein or small saphenous vein, we recommend against treatment of incompetent perforator veins concomitant with initial ablation of the saphenous vein. This is a strong recommendation. Management of ablation-related thrombus extension and deep vein thrombosis after endovascular ablation. In an average risk patient who is asymptomatic following a non-thermal ablation of the saphenous vein, we recommend against routine early post-procedure duplex ultrasound to detect ablation thrombosis, formerly known as endovenous heat-induced thrombosis or DVT, a strong recommendation. In patients who are symptomatic following thermal or non-thermal ablation, we recommend early duplex ultrasound to exclude ablation thrombus extended or DVT. This is a strong recommendation. For patients with acute proximal DVT after varicose vein procedure, we recommend anticoagulant with a direct oral anticoagulant over vitamin K antagonist. This is a strong recommendation. For patients with symptomatic thrombus extension after endovenous ablation, we recommend anticoagulation with a direct oral anticoagulant over vitamin K antagonist. This is a strong recommendation. Management of superficial vein thrombosis for patients with superficial vein thrombosis of main saphenous trunk and tributaries tributaries above the knee more than 3 centimeters from the saphenofemoral junction and more than 5 centimeters in length, whether associated with varicose vein or not, we recommend fondaparinux 2.5 milligram subcutaneously daily for 45 days. Alternatively, rivaroxaban 10 milligram per day for 45 days may be appropriate for patients unwilling or unable to perform subcutaneous injection. This is a strong recommendation. For patients with superficial venous thrombosis of main saphenous trunk, we recommend against using prophylactic or therapeutic dose low molecular weight, heparin and non-steroidal anti-inflammatory drug, although both have been found to reduce superficial venous thrombosis pain and extension, they have failed to prevent venous thromboembolism. If non-steroidal are used for treatment of short segment distal superficial venous thrombosis, surveillance with duplex ultrasound and venous thromboembolism extension is recommended due to the high prevalence of concomitant DVT. Strong recommendation. Management of bleeding varicose vein. For patients presenting with acute bleeding from varicose vein, leg elevation, direct compression, and sclerotherapy should be attempted before suture ligation to control bleeding. For patients with bleeding due to varicose vein, prompt referral to the venous specialist should be done. For patients who presented with bleeding from varicose vein, the bleeding has been controlled.
I expect you to stick to the time because you are the... Okay, no problem.
Responsible vein should be done to control venous hypertension and reduce the risk of recurrent hemorrhage. Patients with varicose vein or venous ulceration should counseled for the possibility of venous bleeding, and their families or friends educated regarding leg elevation and simple compression technique to control severe bleeding. Management of superficial vein aneurysm for patients with superficial truncal vein aneurysm located within 3 centimeters of the saphenofemoral junction or saphenobrachial junction. Open surgical excision with high proximal and distal ligation should be performed. If symptomatic saphenous reflux is present, endovenous or open surgical ablation, phlebotomy or limited stripping of the distal saphenous vein should be performed. For patients with an aneurysmatic superficial truncal vein aneurysm located more than 3 centimeters distal to saphenofemoral junction, endovenous ablation alone should be performed. Thromboprophylaxis in this patient reduce the risk of venous thromboembolism. Patients with symptomatic thrombose or large, more than 3 centimeter aneurysm in superficial vein are best treated with surgical excision. Thank you.
Thank you, Dr. Khalid. Next speaker, Dr. Khalid.
I'm proud to invite Dr. Al-Metwali Rajab to present his lecture titled Role of Lower Limb Compression Therapy in Endovenous Era.
Role of compression therapy after endovenous intervention. Compression therapy is a widespread treatment modality in chronic venous disease. It mainly consists of 4 different compression modalities: elastic compression stocking, elastic and elastic bandage, adjustable compression garment, and intermittent pneumatic compression. The compression pressure stocking are available in different grades of pressure. The classification of pressure vary between countries. One international consensus group, for example, categorizes it into mild, moderate, strong, and very strong according to the pressure exerted by stock. Elastic compression stocking intended for medical use exert a graduated compression pressure, which means compression pressure is always higher at the ankle level than cuff level. purposes of compression according to the hypothesis of Goldman et al. It provides direct apposition of treated vein wall to produce a more effective fibrosis, so improve treatment efficacy, decrease the extent of the thrombus formation that inevitably occur with the use of all sclerosing solution, thus decreasing the risk for recanalization of the treated vessel. Decrease the extent of the thrombus formation may also decrease the incidence of post-sclerotherapy pigmentation. It improves the function of the cuff muscle pump because the compression stocking will narrow the vein diameter, restoring the competence to its valvular function, which decreases the retrograde blood flow. So it reduces post-operative pain and reduce the risk of deep vein thrombosis and improve quality of life scoring during convalescence. What's the external pressure necessary to narrow or occlude the leg vein in different body position? In 2005, Barch investigate that and will find the narrow occur with the median pressure between 30 and 40 millimeter mercury in the sitting and standing position on the leg. Complete occlusion of superficial leg vein occur when the pressure from 20 to 25 millimeter in supine position and between 50 and 60 millimeter mercury in sitting position and about 70 millimeter mercury in standing position. So what's the length for compression? In practice, side length compression devices are prescribed mainly for edema involving the whole leg, mainly caused by secondary lymphedema in patients with a post-thrombotic syndrome after extensive DVT. For superficial vein thrombosis of the great saphenous vein above the knee, and for post-operative use after high ligation and stripping or endovenous great saphenous vein ablation. In all other cases, knee length compression devices are used. Post-treatment compression. In 1960, Figans described the empty vein technique, where the vein should be compressed after sclerotherapy. Furthermore, there exists a wide variation across the globe on utilization of compression after ablative procedure. Post-foam sclerotherapy compression. Cavesi et al. In randomized controlled trial on compression with 23 mm mercury or 35 mm mercury stocking after saphenous castor foam sclerotherapy and phlebotomy of varicose vein recommend that the compression therapy with the pressure of 23 to 35 mm mercury in supine position was safe, well tolerated, and effective in controlling the symptom and sign in immediate early post-operative period after castor foam sclerotherapy of the great saphenous vein trunk and the varicose vein phlebotomy. An overall slight superiority of the 35 mm mercury medical compression stocking have been demonstrated in this study. Berraman et al. A randomized controlled trial on compression following endovenous treatment of incompetent varicose vein by sclerotherapy CONVITI study concluded that the short-term post-procedure compression stocking are beneficial for reducing post-procedure pain. What about compression after thermal ablation? Multi-randomized controlled trial and systematic review on the benefit of compression therapy after endovenous ablation of varicose vein were published. Ayo et al. In randomized controlled trial on compression versus no compression after endovenous ablation of the great saphenous vein concluded that the compression therapy doesn't significantly affect both patient reported and clinical outcome after great saphenous vein ablation. Hong Shou, in meta-analysis on optimal duration of compression stocking therapy following endovenous thermal ablation for great saphenous vein insufficiency, concluded that the compression therapy for long time, 1 to 2 weeks, is better than short-term 24 to 48 hours. Use the term of post-operative pain at 1 week and the recovery of work. Hence, they recommend the prescription of 1 week compression stocking therapy after endovenous thermal ablation in routine clinical practice. Button et al. Randomized controlled trial of compression after endovenous thermal ablation of varicose vein concludes that wearing compression stocking after endothermal ablation is advantageous in the first few days after treatment and is especially beneficial for those having concurrent phlebotomies. Fanma et al. in meta-analysis on compression therapy following endovenous thermal ablation of varicose vein recommend that the routine use of compression therapy with the elastic stocking following endovenous thermal ablation of varicose vein to reduce post-operative pain and the time to return to normal activity. Who et al. A systematic review and meta-analysis on no benefit of wearing compression stocking after endovenous thermal ablation of varicose vein concluded that the wearing of compression stocking after endovenous thermal ablation of varicose vein was not associated with a better outcome except for mild pain relief. So, compression therapy following superficial venous intervention remain a controversial issue, particularly with regard to the indication for and the benefit of therapy. Nevertheless, it is still used by the vast majority of surgeons. However, to compress the great saphenous vein effectively at the thigh level, compression of more than 40 mm mercury is necessary in standing position. But this is nearly impossible to achieve with the elastic compression stocking alone, but it's possible when the stocking is applied on top of an eccentric compression pad placed directly over the ablated or surgically removed vein. What about compression after intervention for deep vein pathology? Leg compression is usually prescribed after deep vein procedure, but there are scarce data on its effectiveness. However, compression therapy is recommended when the symptom persists after invasive treatment. What about guideline and recommendation? Golovichkis et al., a multi-society and multi-speciality writing group on the clinical practice guideline for management of varicose vein of lower extremity part 2 recommends that post-procedure compression therapy for 1 week in patient undergo thermal ablation of varicose vein for pain reduction. Guideline grade of recommendation 2 quality of evidence is B. Thank you.
Thank you, Professor El-Mutwalli, for your very nice presentation, and the most important, because I appreciate your sticking to the time. I hope the rest do the same. Now, we're coming to the last speaker, my lovely close friend, Dr. Hisham Sharaf, Al-Mansoura University. Excuse me, I would like to thank him in advance for 2 reasons. I'm sure he will present a very nice talk, and he will be the only one sticking to the time and finish exactly, and he'll never ask for even second extra. Okay, Professor Hisham. Thank you.
Thank you, Mr. Chairman, for this nice introduction, and I hope that I can stick to the time. First, I want to thank the organizing committee for this invitation, Dumyat Azhar University and Venous Forum in collaboration in this year. I will discuss a very important and challenging subject that venous not acting. Venous malformation, how to manage and diagnose. Venous malformation is the most common type of congenital vascular malformation with increased incidence to 1 to 2 in 1,000 patients with prevalence of 1%. They can cause significant morbidity, pain, discomfort, and the patient, as they can lead serious local and systemic complication. Although present at birth, they are not always clinically evident until later in life and tend to grow in concern with child and without spontaneous regression. Venous malformation composed of ectatic venous channel. Classification in 1863, Virchow published the first classification of vascular anomalies defining angioma, simple or cavernous. In 1982, Malkin and Golowiecki proposed the classification of vascular anomalies according to endothelial characteristics, that hemangioma and non-hemangioma. The Hamburg classification system, first established in 19 88 classification vascular malformation based on anatomic and pathologic feature that truncular and extratruncular. In 1996, the International Society of the Study of the Vascular Anomaly adopted model for classification scheme delineating proliferative vascular lesion or tumor non-proliferative. This International Society of the Study modifying this classification and completing with the recent advance according to genetic and pathologic characterization. In 2018, International Society for the Study of Vascular Anomaly classified the vascular malformation into 4 categories: simple, combined, or affecting a major vessel or associated with other anomalies. Vascular malformation or venous malformation are the result of inborn error in the vascular embryogenesis leading to formation of abnormal endothelium and the result of thin-walled, non-functional and ectatic veins. Greater than 90% of venous malformation are the result of sporadic mutation with majority of phenotypes arising from the endothelium dysgenesis via TIA2 and the BIC, and also for mammalian target tryptomycin pathway. Somatic mutation leads to overexpression of receptor tyrosine kinase, which is expressed on venous endothelial cell, resulting in dysplasia of the basement membrane and endothelium. While only seen in 25% of sporadic venous malformation, a symptomatic mutation of BICS-CA leads to unregulated activation, which affects cell proliferation, migration, and survival. Mosaic mutation in the pathway are also the cause of venous malformation. This is a genetic hypothesis of the presence of venous malformation. Presentation, the present and at birth, venous malformation generally grow with the patient and don't spontaneously regress, and they can present at any age. Malformation due to sporadic mutation are usually unifocal, while hereditary forms such as glomerulovenous malformation and rarely blue rubber bleb venous bean syndrome are more commonly multifocal. Increase in symptoms can also be seen in response to major trauma. When located superficially, they are seen as blue, soft, and compressible mass. Documentation with clinical photograph is critical and is helpful when treatment begins. There are different imaging techniques for venous malformation, like plain radiograph. Small lesion may be occult on plain radiograph. Ultrasound is useful non-invasive imaging technique and should be used as the first modality when investigating the presence of vascular malformation. CT on unenhanced CT, it may appear as ill-defined mass of similar attenuation to the muscle. MRI, hemangioma are typically well-defined, lobulated, and heterogeneous with no feature of local invasion. Conventional MRI has 100% sensitivity in diagnosis of venous malformation. Goyal et al. Classifying venous malformation to 4 grades. Grade 1 less than 5 centimeter with well-defined margin. Grade 2A more than 5 centimeter with well-defined margin. Grade 2B less than 5 centimeter with ill-defined margin, and the grade 3 more than 5 centimeter with ill-defined margin. Venogram with some extensive lesion, a planning venogram may be considered, as direct venography offers the best temporal and spatial resolution to assess the variable pattern of outflow and inflow. Direct venography also classifying the venous malformation to type 1, isolated malformation without discernible venous drainage, type 2 lesion draining into normal vein, type 3 lesion draining into dysplastic vein, and type 4 lesion consists primarily of venous ectasia. Type 1 and type 2 respond best to sclerotherapy, and type 3 and type 4 with higher complication rate. The treatment Option or indication for treatment: patient present with bleeding and close proximity to important structure, a life-threatening area, hemodynamic affection, disabling pain, functional impairment, excessive cosmetic implication, and recurrent thrombosis. The medication, there are different types of medication of the extremity venous malformation, like compression therapy, and the pain from superficial phlebitis and thrombosis may be alleviated by the use of anti-inflammatory medication and analgesic. Main associated with thrombosis, low-dose aspirin may provide relief through the efficacy in poorly described. Surgery for certain lesions that are focal and they respond poorly to sclerotherapy, its indication is very limited because the higher rate of recurrence. Sclerotherapy is the effective treatment and require comprehensive injury to the abnormal endothelium. This relies on two concepts: dwell time and endothelial contact. The type of sclerotherapy, percutaneous sclerotherapy, is performed through ultrasound-guided and contrast injection to the large visualized draining vein. And foamed sclerosant agents are commonly used in venous malformation treatment. Foam, when adequately stable, is able to displace blood within venous malformation and expand within the region, making more extensive mural contact and a liquid alone. Doses used for sclerosing agent: ethanol is very important, 0.5 milligram per kg. Polydecanol, 2 milligram per kg, maximum dose per person. And ACTC, 0.5 milligram to 2 milligram of 3% at ratio of 0.5 milligram to reach 2 centimeter lesion size. Bleomycin, 0.5 international unit per kg. Doxycycline, maximum dose is 300 milligram per session. Sodium morphate, maximum dose is 50 millimeter foam. Cyanoacrylate, 2 millimeter per 2 centimeter lesion size. This is some cases treated by ethanol, and you can see the size of the lesion before injection and the result after 3 sessions. There is marginal response and decrease in size and the cosmetic improvement for this patient. Also, another patient with injection of ethanol under general anesthesia, we demonstrate the size of the injected material by injecting the fluorescent agent, then injecting the ethanol through the lesion. You can see the injection of the dye, then injecting ethanol through this lesion, and this is the direct venography. Other treatment modalities: endovenous ablation and cryoablation. The most commonly encountered vascular anomaly in clinical practice. Understanding the pathogenesis, presentation, imaging finding, and the complication are critical to making an accurate diagnosis and treatment. Treatment options should include conservative, medical, interventional, and surgical approach. Interventional modality are the integral to the treatment of most of our patients. Thank you very much for your attention.
Thank you, Professor. We are all proud of you, Dr. Hisham, but unfortunately we don't have time to ask you and the other speaker. So coming to the closing this session.